Ladies and gentlemen, good morning and good evening to Dr. Rahul in Oregon. I would like to invite you today to our mask ultrasound Zoom meeting with Dr. Rahul. And first of all, I would like to welcome every one of you from different parts of the world to this meeting today. And just to give you a short introduction of Dr. Rahul, he has a very long CV, but I'm gonna just highlight some very important accomplishments that he had. So I've met Dr. Rahul maybe 2015, 2016 in Minnesota, and it was a meeting where we were attending a conference on nerves, and we both speak in the conference. And so I also invited him here in 2016 for the first Asia Oceania conference on MSK ultrasound and regenerative medicine. And it was a very good speech by Dr. Rahul. So just to give you a few introduction, currently he is the president of the Interventional Orthopedic Foundation, which is a 6-year-old meeting organization that deals with cell therapy and interventional procedures using PRP and stem cells, and where you will learn a lot of all this very important stuff with regards to regenerative medicine. He is presently based in Oregon, and he is a musculoskeletal radiologist by specialty. He is doing interventional orthopedic and spine procedures. I would say he is the best in that field. He does a lot of other things in regenerative medicine, putting all together the fat cells, the bone marrow cells, and at the same time the PRP. And this is a very important thing that we can learn from Dr. Rahul Desai this morning. And he runs the Restore PDX in Beaverton, Oregon. He is the founder, the owner, and the physician, and he is expanding his practice. In fact, he is putting up a building primarily for that purpose. And he has also written a lot of scientific journals and has written book chapters in different topics on fluoroscopy, in ultrasound, and do a lot of presentations, teaching a faculty of different fields in TOBI, in IOF, talking about all of these aspects of regenerative medicine. And I am very proud and happy to present to you our speaker for today, Dr. Rahul Desai, a very good friend of mine. And before we begin and we turn it over to him, I would like to ask everyone to have a pause for a moment for a short prayer. Let's pray. Loving Father in heaven, thank you for this life. Thank you for this beautiful day. Thank you again for giving us the opportunity to get together and learn new things that will be presented today by Dr. Rahul Desai. I would like, Lord, to thank you for preserving our lives up to this moment and giving us the opportunity, Lord, to be of service to our patients, and especially to help our colleagues also learn things that will help their patients as well. Thank you, Lord, for your forgiveness and your grace. In Jesus' name we pray. Amen. Ladies and gentlemen, presenting to you Dr. Rahul Desai. Dr. Rahul, it's all yours now.
All right, thank you, Jim. Well, that was quite an introduction, a little bit hyperbole there, but I appreciate it, and appreciate everybody taking the time out of their day, mornings out east, and evening here in the west. But today I spoke with Jim this morning on our time, and I was going to present on a very focused topic, but decided to expand it a little bit and talk about some of the things that we're doing. I'll try to get through as much as I can, and would love to be able to answer any questions, and I think Jim can facilitate that at the end. So what I decided to present on, I'm a musculoskeletal and interventional radiologist by training, and over the past 11 years have been lucky enough to have been introduced to regenerative medicine, and it's really become my passion, orthobiologics. And so the IOF now, it used to be Interventional Orthopedic Foundation, but it's changed in the last year to the Interventional Orthobiologics Foundation, and to be more encompassing of all of the different fields. And I really think that's where this is going, is the orthobiologic therapy. And so today we're going to talk about advanced diagnosis and therapies in joint and spine orthobiologics. All right, no disclosures on the current topic. There's some resources to review, and I can get these to everybody. And if anybody's interested in having the presentation, we can do that too. I want to thank my family, beautiful wife and 5 kids that are allowing me to stay late at work today and present to everybody. But they've been the rock and my foundation, and been able allowed me to do these wonderful things. Another rock and foundation for me has been Jillian Abramson. She's the director of the IOF, and so even though I have that title president, she's really the engine of the organization. And so what is it? I want to take just a few seconds here. It's an entity, it's a nonprofit. So it's a nonprofit entity that provides education, ethics, guidelines, and standards for orthobiologics. This is really important to us as physicians, and I think it's really the future of musculoskeletal care, and we want to take care of it and make sure that it's available to patients. And if we do it the right way, and prove that this works, because it does, done the proper way, then this is going to be available for all of us in future generations. So it is in the U.S. It's a 501c3. It's a nonprofit. It's been around for about 5 years. John Malone gave a very generous donation that's allowed this to prosper, and it's dedicated to educating physicians. We have international members, and we'd love for anybody that's interested, that's listening tonight. It's multidisciplinary, so we have from different fields. There are some criteria, but we have from physiatry to anesthesiology to radiology, orthopedics, neurosurgery, and it's a very structured educational program. We have our 6th annual meeting. It was supposed to be, but with COVID, it's probably going to be online, and there will be some training in Arizona, but the didactics will be online, and then the actual training and cadaveric courses will be in person. That's the hope. So we have a foundations in orthobiologics. We want to teach everybody the foundational pieces and how to learn and understand and be able to critically assess what you want to use and how you want to help your patients. And then we have the actual modalities of fluoroscopy and ultrasound. And then we move through an intermediate spine and joint courses, and then also the advanced spine and joint courses. And I've learned, I thought I was pretty good, but after going here and learning things, it's really helped me become a better physician. And these are all of the different academic organizations that send their fellows, they send their professors and faculty members and students. So it's something that's been excellent. So this is my 3-legged stool. So obviously if someone wants to sit on the stool and get rest or allow it to work, it needs 3 legs. If it only has 2, it's going to fall down. The therapy will not be successful. So for successful regenerative medicine, you need 3 things, I believe, and sometimes maybe there's more, but precision diagnosis, that's a history, physical exam, sometimes diagnostic injections, diagnostic imaging. I'm biased as a radiologist. Precision biologics, I know there's a lot of debate on that. What's the best therapy for what indication, for what use, how many times? So that's the precision biologics piece, trying to get that, and that's a moving target. And then precision delivery. We talk about using the right imaging to deliver the medicine to the right structure. And so once you have those 3 things together, you have
I couldn't hear what you said.
Sorry about that. That's my phone, my watch. We'll put her away. All right, so precision delivery. And so we want to make sure that all of those things are proper, and we're going to have high rates of success when we do that, and looking at, above 80% success rate when you have those things together. So this is a little pitch for the IOF, but also an amazing case. This is an Acl Complete Rupture. So if everybody can see my cursor here, this is a patient that came in, soccer injury, young woman, early 30s, pretty active athlete, and she had a complete rupture. So there's gapping, there's complete disorganization, loose fibers of the ligament, and she also had kissing contusion. So she has a bone marrow edema here and here. So there was translation of the tibia with the femur, and you could have this impact injury. So complete rupture on physical examination too, it was ruptured. And so in the IOF, there's in the advanced knee course, they teach you how to do this ACL regenerative therapy. And so this is a precision delivered therapy, and you can actually see the contrast delivered into the torn ACL, and you can see a little bit of spillage, but this is the tract of the ACL. So we did this therapy with bone marrow, fat, and PRP, a combination therapy. And this was the initial, here, completely ruptured. This second one was about 2 months later, where you have apposition of the ligament. It's still a little bit lax, but it's intact. Patient's starting to feel better and more stable. And this was 6 months out, where it was completely healed. And patient was back to activities and was able to leave with Band-Aids. So without the surgical intervention, there was restoration of the ACL. If you had shown me that 3 years ago, 4 years ago, I probably wouldn't have believed it was real. Another interesting case, and this is something that we're doing more and more of, and I'm sure you're doing that there as well, is augmentation of bone. So this was a small, full thickness rotator cuff tear. This is an MRI. This is a coronal view, and you can see disruption of the fibers. The fiber is pretty atretic, or it's very atrophic and thin. And then you have this defect here. So these are all pre-procedure imaging. The other thing that's evident on this exam is the bone cystic change. And so with studies from Hernigo and others, areas such as this are devoid of stem cells, and there's a really challenging part of this with the tendinopathy and lack of healing at this footprint. And so this patient was a tennis player, older gentleman, severe pain, unable to play. We did a stem cell therapy. You can see the full thickness defect on ultrasound here. There's resorptive changes at the footprint in the bone. And this was the delivery of the material. So you can see it's echogenic. So this is a combination of the bone marrow, the fat, and the PRP, and that was placed into this defect. The nice thing about this is the fat graft is also pretty viscous, and it will stay in this region where injected. Additionally, we did intraosseous injection, where we injected the footprint. You can see a little vascular flow here, but this is the needle placement. And the patient had phenomenal response, still had a full thickness tear. Maybe it was big enough where we didn't completely heal that. And you can see that the defect here, there may be actually a few strands that are connecting. What was interesting though is all the bone marrow edema and that cystic change has resolved. So you can see here, there's the cysts here, the microcysts and bone marrow edema and the swollen tendon. And here you see that the tendon is less swollen, but also those defects have filled, which was pretty profound that we didn't expect that. Here was another patient with end-stage arthritis of the talonavicular joint. And you can see here, large cysts, subchondral cysts, and there's areas of cystic change and basically, bone death in this area, and significant bone marrow edema extending into the talar neck. We did, this is a needle placement intraosseous. You can see it filling actually these cystic areas. And this was the follow-up. So this is pre and this is post. And what was profound to me, the patient was feeling tremendously better, and he's now, this is maybe 2 years old, and he's required another booster PRP, just intra-articular, but has done tremendously well, is relatively pain-free, and this patient was facing a fusion of that midfoot. And so you can see here, this cystic change and basically necrotic bone is now filled in with bone marrow, and the bone marrow edema has subsided in the talar neck. And so this is another area with this sclerotic thick wall and cystic tissue, and now it's filling in. And that was, again, pretty tremendous and profound. What I'm going to talk about for the rest of the talk is going to be spine, and that's my passion. And I have this analogy that I go through. Spine is like a building, okay? And when you look at it, so this is John Hancock Building in Chicago. And the way I describe to my patients the spine is that the vertebrae are the floors, right? So you have the floors stacked on each other, and the joists are where the floors connect. And so for the spine, they connect at 3 locations, okay? The disc in the front, and then the 2 facets in the back. So they're like tripods that are stacked on one another. So those are the joists. The central elevator shaft of the building, right? That's the spinal canal. And then there's elevator doors at every floor, one that goes to the right, one that goes to the left. That's where the nerves, the neural foramen, and that's where the nerves come out. And then you have the ligaments around the spine, and those are the external supports. And why I like this building is that these large struts kind of remind me of that. These are the ligaments that are holding the spine and the building together. And so we want that building to be strong, robust, have a little bit of flexibility, but not too much. And so when we talk about spinal issues, it's not just one piece of tissue. It's not just discogenic. I had a conversation with the patient today. I said, oh, I went to the surgeon and they said they don't think it's my disc. They think it's something else. And when we looked at the imaging, I think it was a little bit of everything, right? That floor, his L4-5 level, was damaged. He had some disc disease, annular tear, some facet inflammation, some instability, and that was causing irritation of the nerve roots, right? He had some hypertrophy of the facets, and so those elevator doors were tight. And so all those things were combinations that are causing his symptomatology. And so those are the spinal targets. So with regenerative medicine, it's there's a book that came out, it's very good, it's called The Power of And. So A-N-D, The Power of And. Because with regenerative medicine, you have a therapy that you can use and you can almost treat with a little bit of impunity because it's so helpful. It's made by you for you, and it's very safe. So sometimes you can choose different targets, and the spinal targets we look at are the discs, right? The epidural space and the perineural space around the nerves, the facet joints, the sacroiliac joints and ligaments, and then also the iliolumbar ligaments, and also the musculature around the spine. And so when we do our spinal therapy, it's pretty extensive. So if we do a spine stem cell case, if they have a bad disc and they have facet arthritis or they have unstable segment, we call it a functional spinal unit. We'll treat everything there. So here's an example of that. So this is at one setting. So we would do the harvesting, we'd create the medicine, whatever we're going to use, PRP and lipo, bone marrow, PRP and lipo, and then we would treat them. And you can see here, this epidural has already been done. And now we're injecting, replacing the needle into the annulus, or filling that. So demonstrating that, and then we're also injecting the nucleus pulposus. Here we're using fluoroscopy, injecting the facet joints, the interspinous ligaments, and then the iliolumbar ligaments. And you can see here that we use contrast to document placement. So here's another example of this was an annular tear and herniation. And you can see we fill that first, and then we deploy the needle into the nucleus and inject that as well. And I thought this was a really nice example of the ligaments around the spine that we treat, right? And so we treat these interspinous ligaments, supraspinous ligaments, even ligamentum flavum, and then the intertransverse ligaments as well. So here's some nice examples of using contrast to document precision placement. We talked about precision placement. So here we're injecting the interspinous ligaments, and here we're injecting the iliolumbar ligaments. So it comes off of, this is 5, going to the ilium, and then there'll be a branch that goes to the sacrum. And there's oftentimes a branch that goes to L4 as well. This was a case of hypermobility of the costotransverse joints and the ribs. You can see here in this picture, you can see the arthritic changes in this joint. And so this is a fluoroscopic view, a steep oblique, that you can open up the transverse spinous ligaments. And so you can see here, costotransverse ligaments or joints, and you can inject those. So there's a nice appearance of this steep oblique, and then we place contrast, and then we did a stem cell case here. And there was also issues with the thoracic disc. So we don't see this very often with thoracic injuries, but this patient had a long-term issue with this, and we treated the thoracic discs as well as hypermobile ribs. So that was a unique case. Another case of SI joint instability. And so when we do a standard sacroiliac joint injection, when I learned when I was training, what we would do is enter the joint itself and not treat the ligaments. And so now with regenerative medicine, obviously I feel like we would be leaving a lot behind if we didn't do both. So here's an example of the injection into the joint and an arthrogram, right, the capsular portion of the joint, and then also treating the ligaments as well and using contrast to document placement of that. Again, this is calcification of the sacrotuberous ligament. We've had a few patients with injury of the sacrotuberous ligament, sacrospinous ligaments. So you can be very specific, and ultrasound can be extremely helpful in delineating these structures, and you can pick up from side to side variations. So why am I interested in this? One is to contribute to the vernacular, right? So we want to change the way of thinking to do this medicine. The other part of this is especially the intradiscal therapies. There's been a lot of discussion that adipose may not be safe. We've been doing this for 8 years now, have over 400 patients treated and documented. We've had 4 cases of discitis, osteomyelitis, so there is risk. And so it's something that we talk to all the patients about. Dr. Lutz had published a paper recently on utilizing gentamicin, and so we've been adapting to that. We use a dual needle technique, IV antibiotics, and also intradiscal antibiotics. And since the introduction of that, we have not, knock on wood, we have not had a case of that. But we want to identify the risks and pitfalls, which we just discussed, and we want to change the narrative of back and neck pain, because the standard of care that we see here is not good enough. We want to make a strong connection with imaging. There's some areas in medicine, orthopedics and spine, that have a hard time believing about discogenic pain, and also physical therapists. And so I think it's a very real issue. I've had it myself. I've had regenerative medicine to my L4-5 disc, and it's been game-changing for me, and so I'm very passionate about it. So we base our medicine on the functional spinal unit. We want to treat the source of pain rather than masking it. We want to treat the structural support of that unit and improve the function and pain and make the tissue more resilient. So the treatment of the functional spinal unit, what do we treat? Disc, facets, we do an epidural, we treat the ligaments, and plus or minus the musculature if there is atrophy or fatty infiltration. So we use BMAC, a lipoaspirate, platelet-rich plasma, or a lysate, platelet-poor plasma, and then if there's large herniations or there may be a staged technique, we'll also use intradiscal and epidural ozone. And that's been very helpful with large herniations. So, there's a fear of the adipose in the disc. Is this warranted? We don't think so. Our intradiscal therapy is a combo therapy. And so this was, this slide is a little bit old. So we had an N of now is about 400. And so I don't even know how many discs that we have treated. But we reviewed the charts for any adverse effects of the therapy, and we want to propose the purpose was to assess the safety and also the efficacy and develop the safest therapies. So I'm going to skip through some of this data because we've added to that significantly. And I wanted to get into some more of the pictures, but we did see both short-term and long-term improvement. And we were looking at about 70% success rate on the first cohort. That has actually increased lately as we treat more structures and are getting more experience with this. This was my first patient that I treated with PRP epidurally, 65-year-old with 6 months of low back pain and left-sided sciatica. And this is not an enlarged nerve. This is actually an extruded fragment. You can see this is the nerve S1 on the right side, and S1 here is over here, so it's squashed. Right? So huge herniation. And the patient came in with severe sciatica and wanted platelet-rich plasma. We did a PRP injection, and this wasn't even the lysate. We did the standard technique. The patient called me a week later and said complete resolution of the sciatica, some minimal low back pain. And so we put him on the scanner just a couple weeks later, and you saw from this herniation, it had shrunk to this. And then we scanned him again a couple weeks later, and basically that herniation had gone away. Now that could happen, on its own, but the rapidity and how quickly it happened and its correlation with that time really started to change my mind, and we started to look into this more. And the more and more we did it, we kept seeing the same types of changes. So you see here a herniation, large annular tear, and then there's this T2 hyperintense herniation. It's pushing on the nerve here. We did an intradiscal therapy with the bone marrow and an epidural PRP, so both in the disc and in the epidural space, and that was able to resolve this herniation and extruded material, but also the annular tear started to resolve and heal as well. And so we see that, and especially with the difference or the delta between PRP and the stem cells, we see much less risk of reherniation, and we're seeing that the annular tears are healing and the tissues are becoming more resilient. So the patient not only is in less pain, but they're able to return to activities that they were not able to do before. We see that less often with PRP, and we've had more reherniations. This is another example where large annular tear and herniation, and it's abutting the nerve. And here, this is post-treatment where the herniation is much smaller, and this annular tear is starting to heal. Right. Another example of a thoracic herniation T56. And we're doing, just like we had that other patient with the ribs, we have excellent results with the thoracic spine. And the benefit of the thoracic spine and the thoracic discs is you have the rib cage supporting it. So there's not as much stress going through there. All right, this was that example of the morphologic changes. So here's another firefighter, large herniation pushing on the nerve roots, and we see that resolution of that herniation. Another interesting thing, I don't have that case here, is that we've treated multiple levels, and we do that not infrequently. And so we're not only seeing resolution of the large herniations, like in this case, we have a large herniation that's resolving, but we're seeing changes in smaller herniations at the same patient, different levels, or resolution, healing, and complete resolution of high intensity zones or annular tears. So it's affecting multiple levels, because there has been some argument, especially early on. I don't get that much as much this often, or more recently, but physicians would say, or non-believers would say, well, that herniation is going to heal anyway. But when you start to see changes of large herniation as well as annular tears, or changes at multiple levels, that's even more compelling. Okay. So here was another case which was dramatic, a huge herniation and extrusion. You can see this fragment here, and this is the post imaging, and we did multiple slices through here. This is about 6 months later, and the patient had dramatic relief almost immediately after the procedure. So within a few days, started seeing improvement. By 6 weeks, pain was resolved, and we scanned them several months later, and the disease process had disappeared. What's interesting with this patient is they were presenting with 6 months of pain before that. So the correlation with the time period is really important. This is another interesting case. This was actually a physician, and this patient was treated with intradiscal stem cells. And you can see the initial, this was before his therapy, severe degenerative disc disease. And this is a fluid sensitive sequence with fat saturation, so like a STIR or a PD fat sat. And you can see that the disc is bright here, it's herniated. The other thing that's bright are the end plates. So he's having modic 1 changes, and you can see these kind of cystic, resorptive, erosive changes of the disc. So with severe incapacitating pain, we treated this patient. 1 year later, you can see the disc is darker, but also the bones are more normal, and you're starting to see more normal appearance of the end plates. And this is 2 years out, the pain is resolved. The patient wanted to see what it was looking like, and you can see a much more natural appearance of both the disc and the end plates. And this edema, this bright in the disc, is not a good thing. It's not proteoglycan or water content. This is swelling, edema, and inflammation. And so that has resolved. Another example, and this was a large herniation extrusion. You can see that here. And this was the post-op or post-procedure imaging. And you can see that complete resolution and starting to see even thickening of the annulus, the annulus on this level here. You can see that. And we see that not infrequently. The next area that we're going to talk about is the cervical spine. So this is something that we went into a little bit later. One is simply, there's more important structures in the cervical spine, and we worry about the vertebral artery and some of the smaller nerves, and just bad outcomes. And so something that I kind of tread lightly on initially. So we started in the lumbar spine, started doing epidurals, and slowly moved into doing the discs. We were seeing such good outcomes there, and when we saw kind of the safety profile of that, we slowly moved into doing cervical spine, including cervical facets, epidurals, and then in the last few years, we've been doing cervical discs, and again, seeing dramatic improvement both clinically and functionally. So we're using standard interventional techniques, right? So this is one thing, is proper diagnosis. This is the normal left side, and this is the abnormal right side. And you can see here, this is the facet joint. It's filled with fluid, right? This is a fluid sensitive sequence. The fluid is bright. And then there's also bone marrow edema. So the articular pillars are seeing swelling as well. We see this quite often, and unfortunately, a lot of these are misread. So there is a schism, definitely in the States, where the radiologists are reading and they're disconnected from the patient. So the patient comes in, they're having severe neck pain, and they order an MRI. Simple things like this are oftentimes overlooked. It's just something that as radiologists, we're trained to see operative issues. So everybody's looking for disc herniation, they're looking for other things on the scan, tumors, vascular abnormalities, and some of the things that are causing patients pain are simply just overlooked or lumped into facet arthritis, multiple levels. And so that puts the clinician at a disadvantage, because if they're in there and they're looking at the report and they don't look at the imaging, they're going to miss that. And I want to talk about how ultrasound can actually bridge that gap. But this is something that's really important, because this was the patient's pain generator, and they had been misdiagnosed for a long period of time. A simple single injection into the joint, even of anesthetic, completely resolves the pain. And then orthobiologics can be that second adjunct if the pain comes back, which it oftentimes does, even with the cortisone injection or radiofrequency ablation, or kind of the standard techniques. Then a simple PRP injection can resolve this process, especially if caught early. So here's another example. This is a non-fluid sensitive sequence, and you can see dark here is edema, and this joint is edematous and extremely angry, and there's lots of spurring. And so this is a facet injection with PRP that resolved this patient's pain. What I'm noticing more and more, and we're doing a lot of point of care ultrasound. So I'm sure most of the docs out there are using that now. And I was really impressed when I was out in the Philippines in 2016 at the amount of ultrasound being used by the clinicians in that conference. And maybe it's just your cohort, Jim's friends that are doing this fantastic medicine, but I was really impressed with the level of musculoskeletal ultrasound that was being done and how often it was being utilized. And we're seeing that more and more in the States. But every patient that I see, if it's a peripheral joint, and now especially the cervical spine or shoulder, I'm always looking at their cervical facets, because we catch a lot of that. The patient, they do have a rotator cuff tear, but they're having periscapular neck pain as well. And it's not all coming from the shoulder, and it can be both. And so then if we're doing a regenerative medicine therapy, it would really be important to make sure that we don't miss something like a cervical facet arthritis that's contributing to the shoulder pain. And so we do that all the time. Here we see the MRI. Patient came in. This was actually just from, I think, maybe 2 weeks ago. A lady came in and she had this almost perfect looking MRI, and you can see the facets on the right side. And when she had a cervical fusion, which is not shown on here, but she was having severe new onset right-sided neck pain. And when I talked to her, it seemed all the world like facets, physical examination, everything. I said, well, this looks like facetogenic pain. MRI, perfectly clean, right? I can't see anything here. When we did the ultrasound, I saw clearly an arthritic joint, and then these are effusions of the joint, right? This is C4, 5, and 5, 6, and you can see significant effusion and bulging of the capsule, and a little bit of marginal spurring and of that joint. The sonopalpation was also very positive, right? So now she's going to come in and likely do an ultrasound guided injection, and we'll have pain relief. But it was clear to me where it was coming from, and it wasn't the shoulder. She actually came in with, quote, shoulder pain. It ended up being, and she had a normal cuff, it ended up being the facets. So I think ultrasound evaluation of cervical facets is extremely important. It's something that can be done in the clinic at the time of examination. And then, if you have the facilities to be able to inject the patient, even with dextrose or anesthetic, it can be profoundly effective. That not only did they come in, you were able to diagnose them, but also before they left, you're able to treat them and take away their pain. And I think that's the way, point of care musculoskeletal care will be moving, and ultrasound is going to be a fantastic tool in our tool chest for that. And here's another example of how you have to change the angle when you're looking at the different level of the cervical facets. And here you can see a little bit of spurring and small effusions of these joints. This is an example of long axis injection using a curved probe. You get a lot larger field of view, and this is kind of the orientation that you would use. So this is beautiful Oregon. I'm actually originally from the Midwest in the United States, so Ohio, and we moved out here about 12 years ago and absolutely love Oregon, except when the forests are burning. But most of the time it's absolutely beautiful. And this is Sisters, Oregon, in the middle of the state, Eastern Oregon, and it's absolutely gorgeous. But that's what the cervical facets remind me of oftentimes, is that we can tell the different mountains, like so the large mountains with a lot of spurring, so you can see these are different, or the nice smoother smaller ones that's kind of the more normal looking facet joint, and these are the arthritic joints. You can see the gap here is the joint space, And here you can see an osteophyte, here you can see an osteophyte. So kind of reminds me of the Three Sisters, and we talk about like, which, is it a hill or is it a mountain? If it's a mountain, it has some arthritic process there. And here's some examples of that. So you can see here, this is an effusion, the joint space. Here a little bit more spurring, right? And capsular uplifting. And here is a little less. The capsule is not as swollen. Another example of a patient, and I'm seeing this more and more often, and as a musculoskeletal radiologist, when I see this in clinic, it's like, okay, there's arthritic joint, there's actually fluid in there. You can have them move or bend and you can see the fluid bubble up. And I said, okay, I could definitely see this on MRI. And I'll go back to the MRI and I can't see it. And it's not there, even on the fluid sensitive sequence. Sometimes it is, but it takes, it may or may not be. So using the ultrasound can be much more effective and much more sensitive. And obviously, if you look at it in the larger picture, it can be a lot more affordable and easy to utilize. And so here's an example of a injection in the short axis of the joint, long axis of the needle, and then you can inject it and it can watch actually the joint fill. So one of the challenges here in the US with non-regenerative medicine is if we're using the insurance to inject, say, a low dose or low concentration dextrose or a steroid, we do not get paid by the insurance using ultrasound guidance, which is really unfortunate because oftentimes it would be much easier. You can use a 25 gauge, come in short axis, less painful for the patient. If you're doing radiofrequency ablation, you can actually see the nerve, right? See the medial branch. And so hopefully over time that changes just with the effectiveness of the ultrasound. The next thing that I want to show you is a little bit of, and actually I started to learn this process when I was in the Philippines, working with one of the doctors there to access the cervical disc. And I use a short axis technique, 22 or 25 gauge needle. If we're doing stem cells, definitely 22 gauge, because if we use adipose, it's a thicker substance, so we need to get into a larger needle. If we're using bone marrow or we're using PRP alone, then a 25 gauge should be enough. We use ultrasound to traverse the vasculature, the nerves, thyroid, or if we go transthyroidal, into the disc. And then once we get to the outer annulus of the disc, we'll switch. You get a little bit of purchase. We'll switch to C-arm and then guide it into the disc and then do our discogram. So we confirm with contrast. The contrast has a small amount of antibiotic in it. We assess the flow pattern. We take multiple views of that disc and then we inject the material. So this is just some examples of a kind of standard discogram technique. Some midline approach or lateral approach. And that's the classic, and oftentimes you're going through structures that you may not want to. And so for me is if you have ultrasound and you can utilize that and you can still deflect the tissues, deflect the vasculature, but you can see exactly where you're going, I think that's profoundly effective. And so we use that combo technique. And you can see that here using ultrasound, you clearly visualize C6-7 disc, the esophagus, trachea, carotid artery, and here's needle placement into that C6-7 disc, the annulus. And then we would switch. So we'd traverse these structures, right? So you're actually watching real time where the needle is being placed. And then once you get in the safe zone, then you can convert and change it over to the fluoroscopy. Okay, and so this was an example. One of our patients was having severe left-sided neck pain with radicular symptoms. You can see this asymmetric herniation, annular tear. It's left paracentral and causing some foraminal narrowing and severe radicular symptoms. So this we treated, and we are still taking a right-sided approach. That's with the placement of the esophagus. So we're taking a right-sided approach, but then the injectate will spread to both sides. All right, so this is that fluoroscopic view. So we use ultrasound to get to the disc and then convert. What was interesting with this patient, so this is actually long axis view. So cephalad is to the left, caudal is to the right. This is the vertebrae, this is the anterior margin. And you can see here, this bright echogenic material is actually the injected stem cell material. And this disc here and this disc here, they're dark. You don't see that echogenic material. When we look, here's the vertebral body, right? And then if you look here, that's the annulus. So this is an intervertebral disc. And this echogenic material is actually the the stem cells that were injected, almost giving a discogram type of appearance. So I thought that was just really interesting finding with this, that you get that discogram, like when you do a CT discogram, this is that appearance of that, and you can see this here. So just something to, that someone, as we go through this, we're elucidating more and getting more kind of the morphology of what's happening. But some things that are unexpected, and as you go and kind of look at the imaging, it's quite fascinating. So this is kind of an ultrasound discogram of this stem cell injection into that was a C56 disc. Here's an example. This is a before and after. This patient came to us with severe neck pain and radicular symptoms, was actually having a fusion procedure, so multi-level ACDF, 2 weeks from the time that he came into the clinic and saw us. He was brought by a family member that had heard about what we were doing and talked to us about regenerative medicine and stem cells. So the patient was a little bit apprehensive and didn't believe, and he hadn't been exposed to regenerative medicine and stem cells. And so we talked about it, and he said, okay, I'd rather do this than have that fusion if it doesn't work. We're not precluding you from having the surgery done, but you need to give it 2 or 3 months, or if this hand weakness continues and persists, then maybe you need to do that fusion sooner than later. So he took a chance on doing this, and we injected, like I showed you that technique, multiple discs. We did an epidural, we treated the facets, we also treated the ligaments. When you look at this, he has straightening of expected lordosis, right? So straight spine, multiple bulging discs, kind of thickening of the ligament, and he has spinal stenosis, right? I mean, this is a pretty narrow canal, no cord compression or myelopathic change, but you see that it's pretty narrow here, and the CSF signal is lost. We did the treatment. Within a couple of weeks, patients started to have significant reduction in pain, and within 6 weeks, complete resolution of his pain, and he regained strength in his hand and functionality. He was actually losing his fine motor skills. So he came back 6 to 8 weeks later, complete resolution of all of his symptoms. This is the image of that, and you can actually see some height restoration when we were injecting the material. How much of that actually stays, who knows? I don't think it's probably a lot, but you can see here, it's an example of us injecting, and there's actually some separation of the vertebrae. So there's height restoration with some of these cases that can be quite impressive. And this was the after. And so you can see here, this disc material is hanging out here and causing some stenosis and really crowding the foramen. And here is that same level where that has resolved, and there's much more room. Now there's still herniation, there's still thickening, but much less. There's restoration of lordosis, right? And then the CSF signal is significantly more. And obviously the most important thing is the patient was feeling better, and he had restoration of those fine motor skills and strength. One other thing that I want to talk about with the power of ultrasound, and there are so many cases like this, is the evaluation of soft tissues that we don't define clearly with MRI, or we miss the diagnosis. And this is something that becomes more and more important when there's challenging cases. So this patient had come in and was having severe neck pain. And why this is particularly important to me is my wife, this is not my wife's case, she had the exact same thing. And so severe neck pain. And when we scanned this patient, they had very focal tenderness at the C7T1 spinous process, and it was just to the right of midline. And so we looked, sorry, the left of midline. And so we looked at this, and this was kind of in retrospect. I don't know if we picked it up initially, but there's slight edema in the attachment of the ligamentum nuchae on this side and the perimuscular attachments of the spinous process. And you can see here it's a little asymmetric, right? And that's exactly where the patient's pain was. This is left, so this is right of midline. You see that it's dark, it's homogeneous, and left of midline you can see this edema. And so what we did was, using ultrasound, because we can localize this precisely, we injected that tissue with 0.5 cc's, and I did the same thing for my wife, 0.5 cc's of lidocaine, just to see if that was the pain generator, and there was complete resolution of the pain. Both patients, what was interesting is they had calcification. It was kind of microcalcification, but you can see the spinous process here, muscular attachments, and the ligamentum nuchae. You can see that here. This is the spinous process. We're looking with ultrasound. And right here, you can see the spine echogenic calcification. And so we went in this area and injected that, again, with just a tiny amount of anesthetic. I wanted to be very precise and not dilute the entire area. And all of their pain went away, right? And so we see these patients not infrequently with car accidents, right, with whiplash injuries. And unfortunately, most of them, if you have enough birthdays, then you're going to have some C5-6 disc issues. You're going to have other findings that could be kind of red herrings that they may not be the actual cause of the pain. And simple things like this are actually the cause. And so I think that's where, ultrasound steps in. Like, we were lucky to find this on the MRI. We don't oftentimes see that, or we will miss it. And we see this in other joints as well. And we see it in hips all the time, where patients come in, they have a little bit of arthritis in the hip joint, but their actually pain is being generated from calcific tendonitis of the gluteus medius insertion. And it's not read on the MRI, or it's not there. It's not clearly visualized. But when we look with ultrasound, we're able to differentiate. And so as an imager, I like both. I'm biased. I love to have the MRI that gives me the global picture. But then when we're really focusing on things like this, we're able to pick up so many findings that we would otherwise miss. The other beautiful part is, it's kind of lock and key, is now we have a tool to treat it, right? So we diagnose it, even with a small amount of anesthetic. If and when this pain comes back, then we have regenerative medicine to fix it, right? And so think about all of the trouble. We see so many patients that have, unfortunately with something like this, you've seen them, is that it's not diagnosed, but they do have something on the imaging that is diagnosed that's not the cause of pain, and they have surgeries, they have disc replacements, they have fusions, they have unnecessary therapies, and they don't get better, or oftentimes much worse than when they showed up. So I think that's kind of the value of what we're doing here, and now we really have a tool to help us. So just another plug for the IOF. There's a intermediate super course going over all of these therapies: shoulders, hip, knee, elbow, wrist, hand, foot, and ankle. And it's going to be done over 2 days, just because of the risk of COVID and travel and those types of things. They're trying to get the most bang for the buck and really get a high level of education condensed. So if anybody's interested, please reach out, go to the website, or reach out to Julian Anderson, or you can send me a connect, either LinkedIn or through Jim, and we'd love to get you trained and get you more involved in this. All right, that's all I got, Jim.
Okay. Thank you, Dr. Rahul. Thank you for that updates, and really nice to see all those beautiful images and procedures. Can we ask questions now?
Yeah. Should I stop sharing the screen?
Yeah. Right. I have a couple of questions for you. How do you assess in terms of pain a patient who comes with a spine? Sometimes years as well. So
you froze on me there for a second. Sorry about that.
Okay. My question was, of course, we see a lot of patients with spine problems, and a lot of them, we catch them up maybe more than several months or sometimes years. How do we know which ones will respond for these procedures and which ones will not respond?
Good question. I think part of it is, you got to get the diagnosis, right? So what part of, the spine is causing the pain, and then where along the spectrum of the disease process it is. Is it severe? Is the joint completely destroyed and it's an arthritic joint, and maybe that person is better suited for radiofrequency ablation, right? I mean, if there's no joint space left and it's just arthritic and inflamed, regenerative medicine may help, right? But then, you can try that. And then oftentimes what we'll do is we do a lot of diagnostic injections. So our regenerative medicine therapies, they are not inexpensive, right? They are not without pain. Like the stem cells, especially lumbar, what's really interesting is the lumbar cases can cause tremendous pain afterwards, sometimes lasting weeks. The cervical, we don't see that. And maybe just the head doesn't weigh as much as the torso and the pressure there, but it's really interesting that you'd think that the cervical spine would be painful as well. We're just not, knock on wood, we're not seeing that severe pain. But we do a lot of diagnostic injections. So using the prolotherapy, say like a 5% up to 12.5%, we'll use those and we'll treat the areas specifically to diagnose, like diagnostic injections. If they get good relief from that, then at least we know we're in the right targets. Or if it's partial relief, right? So if we do an epidural and I say, doctor, that helped tremendously with this, but you know what? I still have pain, and they may localize their SI joint. So okay, they're also their SI joint, or they may localize their hip, internal rotation. I mean, part of it's physical exam, and then we'll treat all those areas at one time, right? If we're going to go through the trouble of doing a bone marrow, of doing liposuction, of getting PRP, then I would rather treat as many within reason, right? Especially segmental, like if it's in that same kinetic chain, I want to treat all those structures together, right? And then by doing that, I've been shocked. Like there's a lot of patients that I will look at the imaging, and I've been biased by that because when I look at it, it looks so severe, and maybe I didn't give them a chance, right? I said, okay, that looks too bad. You need to do something. And I've been shocked at some of the results that patients do so well, even though the imaging looks absolutely terrible. And you think they're not going to respond, and they respond beautifully. If it were not for the cost, then why in the world would you not do that first, right? If they are relegated to narcotics, to suffer in pain, or to do surgery, then I think it makes total sense to try this first, right? They get to leave with Band-Aids. They'll be in the pain for a few days or even a couple of weeks. And if it doesn't work, no harm, no foul. They can always have the surgery. It doesn't go backwards. If they have that fusion, if they have this major surgery and that doesn't work, it's a lot, steeper hill to climb, because now they have scarring, they have instrumentation, all the other complications from a surgical intervention. So I think this just makes sense to do this first. If it were covered, or they, is a copay for them, right, then who would even question it? It's okay, we're doing this first, and then you can move on to the next step if it doesn't work.
Okay. Thank you so much, Dr. Desai. I've read this article on the causes of spine pain, where they say that the dorsal root ganglion will try to reinnervate the structures that has a problem. Let's say it's L4, L5, and then that area is releasing some kind of a cytokine, bad cytokines, and then the dorsal root ganglion is stimulated to reinnervate that area, which is really the reason for the pain, and not just the disc herniation. So how do you see that? I don't know if you've read that paper, but that was like that kind of opened up my mind that maybe the dorsal root ganglion has a role as well.
Absolutely, and I think that's where I think it's an and. I don't think it's one or the other. Like there's definitely innervation of the annulus, and when that's injured, I think it can be extremely painful. If it sets up in a chronic fashion, and you get this kind of those new nerve endings that are coming in there and feeding that, and then that could propagate the pain. But I still think there's an inherent, just like a fresh injury for a disc, it's going to be painful, right? And if it doesn't heal, then you're going to have those chronic changes even within that. So when we do our therapy, I'd rather cover our bases. Like I can't tell you I 100% know the answer, but what I'd rather do is I have this medicine that I'm going to put in the disc, I'm going to put in the annulus, but I'm also going to inject the epidural space. I'm going to cover the DRG, right? So I want to have all of those bases covered. And we learned that in the beginning, because I was afraid to go in the disc, right? I remember even my first PRP that I did like 9 years ago, it was stressful. I was sweating, not from I just like I gotta put this in the epidural space. What's going to happen? You don't even know, right? You're kind of you do blood patches and they go fine, but you're like, okay, I'm putting PRP in here. This is scary, and the patient does tremendously well, and that's part of the learning process that you have to go through. But those initial injections were really quite frightening. But when the patients do so well and they heal, and then you have the imaging. That for me as a radiologist, that was what cinched it, right? I've probably done 5,000 regenerative medicine cases, and a large portion of those I re-image just from curiosity. Like, why is that patient feeling better? And what's really fascinating is when they feel better, the structure looks better. Like for the most part, it's not always, but for the most part, it looks better. And when they don't get better, it doesn't, right? And so there's a really strong correlation that when that annulus heals, right, that the disc heals, the patient's feeling better. When that massive extrusion is gone and resolves, they feel better. When that tendon, goes from this tendinopathic tendon to a more native looking tissue, they feel better, right? And that's how we diagnose. When it looks bad, we diagnose it as a pathology. So why can't we diagnose it as a healing when it looks better? And then that correlates with the patient's symptoms. And so that's another, when we talk about where discogenic pain comes from, like we've seen so many cases now that we correlate that. We can say, okay, this, patient's feeling better, disc is healed, right? And part of it is I've had that disc injected, and when I had my disc injected, I didn't have any anesthetic, I didn't have any pain medicine, and I had about 17 hours of excruciating pain that I could. So I went through that. I had a herniated 4 or 5 disc, and I didn't expect that type of pain, but it was very informative. But I wouldn't want any of my patients to go through that.
Great. I have 2 questions here one from Jojo. I'm sure you still remember him. Jojo, go ahead. Say your question here. You're asking about the platelet lysate.
Yes, Dr. Jim, thank you. And congratulations, Dr. Desai. It's truly an amazing lecture. Appreciate your lectures all the time, Dr. Rahul. Could you give us some insights on when the best time to use platelet lysate would be, and when would you not use PRP and then use maybe a PRP and a fat combination, and when would you use a PRP with fat and the bone marrow, and for these treatments, how many do you usually do? Do you do just 1 treatment, 2 treatments, or do you space them apart, like 1 treatment every month? I'd appreciate your insights on that. Thank you very much, Dr. Rahul.
Yeah, good to hear from you, Jojo. I want to come back out and see you guys once post-COVID. We'll make some trips. But very good questions. Let's start with kind of the treatment regimen. Okay, and so I have a very standard mantra that I always tell my patients. We get the right diagnosis, we try, or diagnoses, right? So it doesn't just have to be one. We pick our targets, and we pick the best medicine for those targets, okay? We treat them with that medicine, and I'll talk about the stratification. We treat them with that medicine, and different structures take different periods of time. Spine takes longer. I don't do anything with spine after, say, a stem cell for at least 3 months, maybe longer, maybe 6 months. And because I've had patients where we thought we failed, and 4 or 5 months later, it turns around. They've been in pain for a decade, right? And it turns around and suddenly they're better. And so the spine just takes a long time to heal sometimes. So you have to be patient with that. But the way I do it is we do the treatment, and at that time period, I'm gonna ask them 2 questions when they come back. I have distilled this to try to make it really, I'm a simple person. I was like, try to make it as simple as possible. Number 1, is it helping you? And number 2, when do we do it again, right? Number 1 question, is it helping you? Are you a responder? I wanna see at minimum 25% improvement. I wanna see 100% improvement, and we never have to do it again. High five, we'll see you when we see you. But at minimum, are they responding? 25%. That puts them in the responder category somewhere 8 weeks plus. Second question, when would we repeat the therapy? Is if it plateaus. So they're doing well, better than they were, but then it's stuck. Say 25%, 50%, and it's not moving anymore. That's when we would re-energize it. And when I do a booster, if we did stem cells first, I just use the PRP or some form of lysate or some form of that, not the stem cells again. If we start with PRP and we get a really good response, 50, 75%, I'm probably just gonna do PRP again. If we have a good response and then it wanes and we're not getting traction, then we can talk about moving to stem cells. The other time that I would consider repeating it is if we get 100% or we get phenomenal response, patient's happy, quality of life is restored, and then at some point in the future, the tissue starts to deteriorate, okay, or symptoms come back, that's when we would give them a booster. And then so, the other thing is when you talk to patients, be transparent with them. Is this a healing therapy? Is this curative, or is it maintenance? If someone comes to me and they're a KL4 knee, I'm going to tell them first time I talk to them, this is maintenance. If you have more birthdays and you're active enough, which we want both to be the case, you'll be back, right? At some point, the pain is going to come back, and then we'll try to. my guarantee to you is that we'll try to do it as cheaply and effectively as possible, but you're coming back, right? It's not going to be fixed. For other things, and we see that with like disc or tendons, like you saw some of those pictures, this could be curative. Now, it may take me 1, 2, or 3, tries to get you to that point where it's fixed, like tissues coming together, right? I say, this is where you are now. We're going to treat you, and it may feel really good here, but if it starts to come apart, you're going to feel symptoms again, and I'm going to treat you again. And it may not be fixed, we'll treat you again, and then maybe at that point, it doesn't break anymore. It's more resilient. So that's my philosophy of how to treat patients longitudinally. How to pick the different treatments, it's a big question, but I'll try to break it down simply. If there's a defect and I want something to stay and stick, I'm going to use fat, right? If it is a severe issue like a disc, which is really hard to heal, I want all the cells. Dr. Harrell told me back in the day, like the cornucopia of cells. I want everything. Like Thanksgiving, give me all the food, all the different stuff. And so bring it all together. So that's when we use bone marrow fat PRP when something is really injured. Discs are hard to heal. They're highly avascular and they're really challenging. And so you want the strongest therapy, and then you put it together. If you're treating a tendon and it's a small defect, what I found is the PRP, it may make it feel better, but it's just so non-viscous, it's so fluid, it flows out of there. Where I put the fat, you saw that picture, and it stays, it's viscous, it's like a graft. So it sits in those defects, and then it can help that heal, right? It creates that scaffold. So that's why I like that. As far as the lysate, what you're doing is you're getting rid of fibrin cell bodies. And overall, you might even have a net, there's a little bit of debate on that. You might have a net anti-inflammatory effect. So it's very soothing, right, for nerves and soft tissues. And so when you have something that's highly inflammatory, so somebody comes in and they have a super hot bursitis, you don't want to put a leukocyte-rich PRP in there. You want to go all the way at the other end of the spectrum and use like a lysate, right, or A2M, something like that that's really going to calm down. And so that's where, like with nerves, they're delicate, epidural space, I've just found a lot less reactivity. And again, I've had it done as well. And the lysate is soothing. Like you inject it and it does not hurt. Like the last time I had, fantastic doctor did for me like 6 epidurals, facets, ligaments. I was sore and stiff that evening. The next day I did cardio, like some exercise. So that's how soothing that was. And so that's a really nice for epidural space, for nerves, so hydrodissections, those types of things. I like the lysate for those. Okay, so hopefully that gives you the stratification of how we do things.
Okay, thank you, Jojo, for that wonderful question. Pash, you have a question here about Modic score, so go ahead.
Yes, thank you, Dr. Desai, for that lecture. It was really something that I couldn't miss to watch, and it was really great. Anyway, so Doctor, regarding the Modic score type 1, did you have to treat the patient also with some form of antibiotic? Because of course, it's something that sometimes remind us that these are infections that could be ongoing or inflammations when it's a Modic score type 1. And if you did, which one came first? Was it the antibiotic treatment or was it the orthobiologic treatment? Thank you.
Yeah. Thanks for keeping us safe with the mask. Yes. So it's a great question. We do not do prophylactic antibiotics before. So what we'll do is we'll do the like an Ancef, gram of Ancef IV an hour before. We do a Hibiclens bath the night before, and then we also do a gentamicin. There's a formula, and Dr. Lutz has published that information, that we inject that with the contrast into the disc. The infections we've had, presumed infections that we've had, have all been men, middle-aged, all have had modic changes, not even at that level, but other levels. And they've had end plate intrusions. So like the Schurman's type of disease process. So something is amiss with their end plates. And I'm not even, like we've sent those patients for biopsies, right? So bone-to-disc bone biopsy, a couple to the hospital, and we have not been able to culture anything, okay? So it's a bit of a conundrum that, is it really infectious or is it an inflammatory? process, and they also show up kind of atypical as far as when they present. Several of them have presented 6 weeks later, and so it's a little bit confusing of like the infection shouldn't present that late, or at least that's the assumption. Okay, so I think that one thing is stratification, that if you see a patient, and we actually have one coming up here soon, and that's a great question, is that we're going to treat them prophylactically 2 weeks prior with antibiotics, because now we're seeing that, okay, we haven't had no women have had no women have had an infection, and then all of them have had, you get the tougher sex, right? And all of them have had some changes in different levels. And so that's something to look at, is when you're doing these, if you have that patient and you're seeing like a Schurman's process, the end plate intrusions on the MRI, then just be cautious, or maybe put them on a antibiotic, or do the extra-discal therapies first, right? Do epidural, do facets, do ligaments, maybe skip the intradiscal at that, for maybe that first round, and see if they can do well.
Thank you, doctor.
Yeah. I have one last question, Dr. Rahul, from Dr. Sajad. Would you like to ask your questions directly? Hello, Dr. Sajad? Are you around? Well, I think it's understanding. Anyway, the question is about how much volume of PRP do you inject in the epidural space?
So usually I'll put about 2 cc's per level if I'm doing a transforaminal injection. And then based on that, if I'm doing, say, a central, we want a broad, spectrum spread. Usually I'll put up to like 7 or 8 cc's for a lumbar, and 5 to 6 for a cervical.
Okay, that is an ml.
Yeah.
Okay, so do you always do that as a protocol when you inject in the epidural space, where you have to go to the specific level, where is it painful, or you can go from the caudal area and then just inject it from there?
Yeah, the only thing with the caudal is the volume, right? It's just making sure you get enough volume, and there's just less control in caudal. If you have adhesions or you have some other things, then you may get, even if your needle is to the right, you've seen, when we're doing caudals, that it'll preferentially fill left-sided, right? And so the contrast will go, and you don't want to get that beautiful Christmas tree appearance in the sacrum, but sometimes for whatever reason, if there's adhesions or scarring or, inflammation in one area, that, the medicine is going to go in the path of least resistance. And so you may not get coverage. So what if we just want broad spectrum spread, we can do that. But if we definitely have, say, foraminal stenosis, and we think like that DRG is injured on that side, or there's some reason to have that, then what we'll do is I'll do even multiple levels. Like sometimes I'll say there's stenosis at all these levels. Instead of doing a central and bathing everything, I'm going to go just transforaminal, because I really want to get into that neural foramen. So it is highly individualized for that reason. The only word of caution for doing a caudal is spread, because it's just a little bit less control. Not to say that it won't go everywhere, but I've seen it preferentially go to one side or the other, and it may not be the side that you want the medicine to go to.
I see. So is it like when you inject the epidural space, do you do it under fluoro, or can it be done under ultrasound?
I like fluoro, and it's because I want to see where it's going, right? You can enter, like I've had some patients where body habitus, or for whatever reason, I want them doing a caudal, and I'll use ultrasound to access. I just can't, feel the cornua. I can't see exactly where that is, or for whatever reason. And if I can use that to gain access for the needle, I'll start it that way. But I will, because I have the fluoroscopy in the same room, I want to use that tool to see where it's going, because I will put contrast in and see that, okay, I'm getting coverage to where I want it to go. And the same thing with cervical. If we're doing, I don't do transforaminal cervicals. So I do central, but I'll go up to like C6, 7. But then I will use like a Trendelenburg technique, that if I'm injecting and I'm seeing more go thoracic, then I'll put them in a Trendelenburg and make sure that I'm getting cephalad flow before I put the medicine in, the lysate. So I feel it's important to see, and then I want to take pictures of like, okay, that it's hitting. If I want to get to certain levels, I want to make sure that I see that that image.
Okay. One last question, Dr. Rahul. When you process your bone marrow, do you still use your centrifuge, or you don't centrifuge it anymore? You use it directly.
No, I use the centrifuge.
Use the centrifuge.
Yeah.
Okay, because
So
I've heard some people not doing centrifuge anymore. They just harvest from different spots in the cortex of the hip, and then just direct. So you still centrifuge it.
Yeah, our cell counts are definitely, we have, our cell counter, and there's a difference.
Oh, there's a difference.
Yeah, you will concentrate the material better. And if you're going for a highly concentrated dose in a small area, then you want to use the centrifuge.
I see.
I mean, the problem with the one kind of downside with our technique, I guess, as far as, quantification, is the fat. Right, and we were using a fat graft. We're not able to quantify the cells, but with the the platelets, you can quantify that, and then also with bone marrow, you can get at least cell counts. I mean, there's more sophisticated ways of doing things, but at least we get that. And we've definitely seen a difference. Okay, so I think it's important to concentrate, but again, I think there's probably better cell scientists to talk to about those things than.
Right. But when you inject them together, do you inject them like bone marrow first, followed by fat, and then followed by PRP, or you just put them all together at the same time?
Yeah, same time.
Same time. So it doesn't matter which comes first.
Well, it depends on where you're putting it, or you can actually create a slurry if you want, depending on where you're on what you're trying to achieve. But if you're doing like depending on what structures you're treating. Right, so like you say, if you're doing epidural, you're using a lysate, right? If you're going to treat the disc, then you may want to use all of them. And then also, depending on how much volume you get, if you're doing many areas, you may have to do some planning on where are you going to put your strongest medicine, right? And then what can you use other kind of the leftover stuff, right? Where are you going to put all the different things? So you may have to stratify or kind of rank list your most important, your key structures. And so when we do our therapies, we have the big tray, and we prepare everything first. We label it, individualize it. So I have all the disc treatments, set aside, and then everything else is here. And then, if we're doing a large area and we're treating the ligaments, that may just get the PPP because all the other stuff is already utilized for other structures.
Well, I was impressed by the complete ACL injury that you showed us. And when you treat this, did you ever immobilize it for some time? Immobilize it after the treatment of stem cells in the ACL?
Yeah, so we immobilized her braced non-weight bearing for, I think, a week. So we definitely, so we immobilize, and we want to, that with that complete, we just want that scaffolding to start building. I just think of like these, cells crawling and building that matrix, and we wanted to get it stable enough and clot. But we've done several. We've had one failure. So a young boy, that was our first one, and not too long ago, but he ruptured it completely afterwards. But he was doing really well, and he went back to playing sports, and it tore. And I think that there's looking at that, we've had such good success. That was our first one that it was failed. And we've had done probably, 15 full thickness or complete ruptures. And we have follow-up imaging. We have the, the KT 1000, the KT 1000 or something. So the machine that shows translation and going from like 11 to 2 millimeters, so, and becoming, equal with the other knee. So though we haven't done like the Biodex is another one that somebody had mentioned to me as far as like testing, but we have the imaging, and patients are returning to sport and feeling much more stable. So it's pretty amazing that there's some good literature on partial tears, but with these full thickness ruptures, it's amazing how that's coming together. But I think that there's probably a good thing to, a study to look at is where the tear occurs, right? Is it mid-substance? Is it proximal? And there may be a stratification on, okay, if it is this type, then maybe it's better to to have the surgery. But where I see the ACL and the complete ruptures really changing the way that medicine is done is in adolescence, right? These young athletes that tear their, I have 4 daughters, right? And if they get into sports or something, there's a high chance that one of them's going to tear their, and they're all into the sports, at least swimming. So ACLs are not commonly torn with that. But if they do tear, you know, I'd much rather, and especially kids that their growth plates are not closed, they're doing reconstructions right now. I mean, there's new techniques, but why wouldn't you try this, right? And the beauty of this is you could start imaging as early as 6 weeks, right? And if it's going to heal, you're going to start seeing it. Like if you see those changes where, you know, it was blown apart and now it's starting to come together, right? Then let it heal. Don't mess with it. Don't do surgery. If it's still blown apart, go do surgery. So you don't have to, and you know, there's not a rush to do the ACL reconstruction, right? So you can buy some time, do this, like it's so easy, right? I mean, it's such a simple technique, and it's a needle. It's a 22 gauge, you know, needle that goes in the knee, and they leave with Band-Aids.
How many months was the tear from the treatment? Did you know how long was the duration?
Well, we've had numerous ones. I mean, I think the fresher it is, the better, but we've seen ones that are, you know, like 4 or 5 weeks out, 6 weeks out. Yeah.
That's the longest you have.
Probably. I'd have to look back. That's a great question. I don't think I looked at that, but definitely not like long-term chronic tears. I think that's going to be harder.
So you were using ultrasound, or you were using fluoro during your approach? Fluoro.
That technique is fluoro, and ultrasound is challenging. Like to really get that nice, because we're trying to treat both bundles. So that I think is, even though if it's, you know, it's completely blown up, we're kind of hitting those areas, but we want to see both of the bundles get some of the contrast in cells.
So when you inject it in the ligament itself.
Yeah.
Not in the joint.
No, well, we inject the joint as well, you know, just to kind of chondroprotective effect.
Right.
If there's, you know, meniscal contusion or injury or even cartilage injury, like you saw that that impact, right? There was definitely some, I'm sure there's cartilage injury or softening in that joint. And so we want to have like that chondroprotective effect, inject the joint. But we'll, you know, when we did those, you know, some of them, we treat the ACL, the MCL, anything that's injured, and meniscus. So I think, you know, treating those, all the structures is going to provide for stability.
Okay. Thank you very much, Dr. Rahul, for your time and for your effort. Although there was one more question here, and the question was, what type of PRP? Maybe we all agree that PRP should be 3 to 5 times baseline, right? Because there are PRP right now who's like PPP actually.
Yes. Yes.
Anyway, so thank you very much for all this lecture, and really would like to see you soon.
Absolutely.
When all these COVID challenges is over, and might do some other lecture somewhere. Okay, Dr. Domingo is raising his hand. Yes, Joe. Do you have a follow-up question? Hello, Joe. Okay.
Oh, I just wanted to say thank you to Dr. Rahul. That's all.
Okay. Dr. Rahul, we really
See you soon.
All right. Everybody be safe. And thank you, Jim. You take care.
Thank you.
Have a good day.
Yeah, thank you. Have a good day.
Okay. Bye-bye.
Bye-bye.